Before I begin, I'd like to share an incident. एक दफ़ा यूएस में एक फंक्शन था, तो वहाँ पर उन्होंने एक पाकिस्तानी कपल को भी बुलाया, तो 8 बजे का फंक्शन था, एग्जैक्ट 8 बजे पाकिस्तानी कपल पहुँच गया. तो एवरीवन वाज वेरी सरप्राइज्ड कि यार यू पाकिस्तानीज आर नोटोरियस फॉर नॉट बीइंग ऑन टाइम, तो व्हाट्स द थिंग. तो उन्होंने कहा कि बाकी सबको हमने 8 बजे का टाइम दिया था, इन्हें 6 बजे का टाइम दिया था, तो हमने भी एक्चुअली 9 बजे ही स्टार्ट करना है. So I thank you all who took out the time early in the morning on a weekend. I know it's tough being a student and all. I know how personally tough it is. So thank you very much for taking out time. A few announcements before we begin. First and foremost, put your phones on silent so that people are not disturbed. Secondly, please sign your attendance for the CME. ठीक है, जिस तरह कुरान में है कि आपके अमाल ज़ाया ना हो, तो इस तरह भी आपकी CME ज़ाया ना हो अगर आपने अटेंडेंस ना साइन की हो. So those of you who haven't signed, please, you can go outside and sign and mention your PMDC number as well. Finally, if any of the speakers have any presentation that they want to give and they have it on the USBs, then please submit it to us now so that we can incorporate it beforehand. So officially to start off, I'd first of all like to welcome Professor Aslan Ahmed. He's a consultant neurologist at Shifa International Hospital and Shifa College of Medicine, and he is the local site organizer. He'll be explaining the basics of this programming.
Assalamu alaikum everyone, all friends right now. I'm honored to see big faces, senior people come here early in the morning on the weekend. Now, we started planning this meeting about 1.5 years back. When I think it was a couple of years back, Nadir, when we had that PSN meeting in Karachi, in which Nadir managed to invite 2 or 3 big people in movement disorders, and we had 1 full day of movement disorders. So that got the ball rolling, and after that Javed was also there, and we started thinking of one complete meeting of movement disorders in Pakistan. So now we have the realization of that meeting. It's a full 2 days conference with Javed has taken out time and flown in, Nadir from Karachi, Asif Bashir is a functional neurosurgeon who's come in from USA. There are, most of the people from all major cities are here. Yesterday, I was so happy to see some people even from interior Sin, consultants, flying in to attend the Botox workshop, which was very well done by Danish Bhatti. So I think it is time that we have subject-specific meetings, as we were discussing. A few years back, Pakistan Society of Neurology, the Pakistan Headache Society, first of all, set up a certificate course and planned to train GPs. After that, for I think in 2 years, in 2013 and 14, Dr. Aziz Sanawala's leadership, we managed to train 1100 GPs in headache. And now over the next 2 years, the Pakistan Stroke Society has made standardized lectures and plan to train 1000 GPs in stroke. Similarly, Dr. Fawzia Siddiqui for several years has been conducting an epilepsy mini fellowship, which is a 2-day mini fellowship design. They give a certificate and they have a structured course curriculum with structured lectures which are delivered by different consultants. And that is a big benefit for pediatricians, neurologists, general physicians in this region and in the smaller cities. So it's time that we have a movement disorders meeting, and we have a movement disorders group, and we start training our physicians, especially in this field as well. We have a lot of Parkinson's disease, we have an aging population now, we have a lot of Alzheimer's disease. So and there are very few neurologists. I don't think now that in our lifetime we'll have enough neurologists that Pakistan needs. So we need to train our physicians. I'm very thankful to my team who have put in a lot of effort, my colleagues, Dr. Mohammad, Dr. Athar, and Tanveer and Athar, who've been putting in real extra time, and they were here all night setting up stage and everything. And the sponsors, mainly GSK are the gold sponsors, and Novartis the silver sponsors, and then the other pharmaceuticals are also sponsoring, who are the ones who have taken the stalls, OBS and Barrett Hodgkins for the Botox, as well as Hilton Pharma. I hope I am not missing anything. Hilton, Bayer, okay, that's about all. I would now like to invite Dr. Javed Bajwa to give an overview of the program. In addition, what we have done is we have printed the PDF copies of the whole program, of the lectures that are going to be taken. And those, everyone who registers will have that booklet. It's got all the material. I know that, the people don't absorb everything that is given in a lecture, but they'll have this handout with them for ready reference. And I hope that this will go a long way. One more thing, all neurology residents are invited to stay back at the end of the session. The last session of today is the difficult cases session. And we'll have a small strategic meeting in which we will decide how we are going to proceed with propagation of this movement disorder society. So be here, in those who are interested, just stay here after the end of the session, and we'll have a short half-an-hour meeting at that time. Thank you.
All right, so before we let Dr. Javed Bajwa take the stage, we'll have to introduce him. He's the Assistant Professor of Neurology at King Saud bin Abdulaziz University of Health Sciences, and he's also the Program Director for Parkinson's Movement Disorders and Neurorestoration at the National Neuroscience Institute, King Fahd Medical City in Saudi Arabia. So please welcome Dr. Javed Bajwa, who's flown directly from Saudi Arabia to attend this meeting.
So, thank you so much. Assalamu alaikum to everybody. Small audience, but that's okay. I've seen smaller than this as well. So if you're going to start at 8, then you have to pay a price for it. So alhamdulillah, I think Dr. Salan pretty much covered most of it. From my perspective, I think I wanted to just welcome everybody. I think it's a moment to be rejoiced and to be remembered for long, because the first is always the first, right? Your first child, your first car, your first medical degree. If that was fake, then you got a new one, whatever. So the first has always a huge emotional impact for many who are involved. So I think the faculty, the organizing team, the audiences, the delegates who are all going to be here for the next 2 days deserve appreciation and recognition for being part of a momentum and a change. It's never easy to do the first. There are always barriers, there's challenges, there's unknowns, and I think we just have to do it and take risks. So with that, I would say that welcome to everybody, and I hope to see, as some of us are visiting from overseas, but we're very well connected now to the neuroscience community in Pakistan, and we'll do our part and our share to make it flourish and keep it engaged. And as Dr. Hassan said, I think last year we were at Aga Khan and we started talking about this. So I'm glad to see that we were able to accomplish within a 12-month calendar year. Things can keep on going and you can keep talking, but it's nice to see something happen. So with that, I would really like to thank Dr. Arsalan, Dr. Vase, and their team. Many of them I just know by emails and names, who have really put in tremendous amount of effort to do this. So I think great recognition for the organizing team, and they're spearheading the whole effort. Our role from overseas was very different, but the legwork, that vision would have never been completed if there was nobody on the ground to make it work. As I say, ideas are always cheap. So you can spend hours talking about great ideas, but only few ever get to do it. So I think that deserves it. So Pakistan Society of Neurology, the faculty who's here, and sponsors and all the delegates, so wholehearted congratulations and thank you. And I wanted to point out, I think it's an opportunity for us to understand that what is happening outside of Pakistan, although Pakistan is tremendously huge. We're talking about 200 million people. That's almost 3/4 of the size of the United States. So if you look at the impact of this population, it's no less than some of the mega-sized countries in the world. but we have our challenges. But Asia generally has been looked at in terms of a less aging population. But by 2030, the incidence and prevalence of Parkinson's disease is expected to double. And we're expected to have anywhere between 30 million plus people globally affected with disease. That biggest chunk of number is going to come from Asia. That's not going to come from Europe or the western side of the equator, but north of the equator, but it's going to come from Asia. So aging populations like ours, Far East, Japan, Korea, all of them are facing the same challenges. That are we ready in the next 2 decades or 10 years to offer services? We're not even ready for now. And I don't think any healthcare system will be well equipped, and that's even true in the United States. But I think an effort is deserving to bring about that change that is required. So I think that is the precipitous, and this is why the Global Movement Disorder Society, which has very heavily supported this meeting, and some of the curriculum and everything came from a lot of the well-known authorities in the society, has really admired this initiative in Asia, Middle East, and now Pakistan, that we're engaging the conversation that this is an unmet need significantly. So in US or in Europe, you've probably been to how many meetings you need on Parkinson's. There's quite a bit of information, literature. Everybody knows the ABCs, so you know how much. So they're all looking at this underserved communities of the world where there's still a huge vacuum. So I think so this is just to give you the global and the regional need, that even though we're a nucleus, but it's all connected. Everybody is sort of moving in the same direction. Now, I would like to also talk briefly about the Movement Disorder Society. I think it's something that could be hugely beneficial to us all. And some of us who are members or actively participate find it very meaningful. One of the things that you guys all have, and I've been sort of stating it every time I've been to Pakistan, is what we call associate membership, which is for $0 value. What it does is that it gives you, to be a member of the society, access to every educational tool, journals, online schools, ratings, for $0 because you're from an underserved country. So Pakistan falls in that category. You just have to go online, click on associate membership, click on no waive dues, and then submit the application, and within 4 to 8 weeks you'll get your ID number, everything, and you have not paid a single dime for it. I think it's a tremendous tool. MDS pays for it eventually, but it's a need that we feel that most communities may not be able to afford the typical $300, $400, $500 membership annually. So I think I would encourage everybody, especially the young residents, that take use of that, because you will find tons of stuff on Parkinson's and published data that could be very meaningful. So I think that the other thing that I think is very meaningful, that the Asian section of MDS has a fellowship program. So we support a fellow from Asian countries within a host site within Asia, and we sponsor their salary plus their benefits to the host institution. So as an example, if somebody from Islamabad applies, application is reviewed, he's interviewed, he's selected, and the host site is in Australia, for example, and MDS says, yes, he's a good candidate, and the host site accepts, MDS will pay for your travel and your salary. I think it's a tremendous opportunity. I've been saying this for 2 years. We have never seen a single application, because I'm part of that committee. I've never seen a single application from Pakistan. There are a lot of people apply from India, a lot of people apply from Nepal, Iran, a few other places from Middle East, but we've never seen a single applicant from Pakistan, which I think is a tremendously added. You don't have to pay, and you get your training, and you come back to your host site where you started. So I would encourage everybody to Google that. Someday, tomorrow I have my talks, I'll be able to share the link with you as well. But do keep that in mind. Just Google Movement Disorder Society, AOS Asian Fellowship, and you'll get the link. It's a simple procedure. I think we just ended for this year. We picked up our candidate, but I think it opens up at the end of each year, and then we go into the next one. So keep that in mind. I think the slides are not up yet, but I was going to tell you the next month we have our regional meeting in Dubai. I think few of you are going to be attending that. So it's our second Middle East camp for Parkinson's, movement disorders, neuromodulation. So if you can make it, it's a much more detailed program, a lot more elaborative, so it's worthwhile. And then in March 11 to 13, we have our Asian Parkinson's Congress in Manila, Philippines this time. So that is another opportunity, because sometimes you may find restrictions going to Europe and US. So maybe this track may be much more doable and easy in terms of securing visas and travel permissions and whatnot. So keep those two meetings in mind. So with that, I will end a little bit of my introduction, and I thank again everybody for being here, and I hope you take the home message over the next 2 days.
So the first session, first of all, I'd like to introduce our chairperson. Our chairperson is Professor Mohammad Tairq. He's the senior most neurologist in Islamabad, and he's the ex-professor of neurology at PIMS. Our co-chair for today is Professor Muhammad Subhan. He's the professor of neurology at Peshawar Medical College. So I'd like you to please come up on stage. So the first topic of the first session is Functional Anatomy and Physiology of the Basal Ganglia by Dr. Danish Bhatti. Dr. Danish Bhatti is an assistant professor of movement disorders. He's the director of the International Neurology Program, curriculum director of Movement Disorders Fellowship Program from the University of Nebraska Medical Center, USA. And yesterday he was the one who conducted the Botox workshop. So I'd like to welcome Dr. Danish Bhatti on stage.
All right, let's get started with some serious business. Basal ganglia. So my hope today is to describe the anatomical structures and connections of the basal ganglia. And more importantly, what I really want to do today is to outline the theories of the functional connection of basal ganglia. You know, we all went through the medical school listening to an old classic model of basal ganglia, the direct and indirect pathway. But my hope is today to summarize the recent advances in our concept of functional connection, and then really take a further stab at understanding the newly evolved concepts of neurophysiology of basal ganglia. That okay, these circuits are there, connections are there, but what do we really see in basal ganglia now that we can get to basal ganglia with procedures like deep brain stimulation surgery? So we put a wire in and we are in the basal ganglia. We can record an electrical current for them. When we record an electrical current from an active basal ganglia in a live human, what do we really see? And how does that connect with what we know about basal ganglia? But a quick recap on basal ganglia. So what is basal ganglia? You know, I thought the best description will be the function of basal ganglia. Way back, David Marsden from England, really a legend in movement disorder, described basal ganglia as the key structures responsible for execution of a learned motor plans. So it doesn't make the plan, but it is involved, is the key structure in the execution of the motor plan. So how does it do it? It facilitates the internally generated movements. It suppresses unwanted motor behavior, which is extremely important phenomena, and that is probably the key of movement disorder, is the lack of the suppression of unwanted movements, and that's why we get the motor phenomena of movement disorders. It smoothens the fine motor response, and then more interestingly, more and more we're learning that it has an integration of behaviorally significant events and rewards. So it not only has a connection with limbic system, but it is the integration of the rewards from the limbic system into the motor patterns. So it facilitates certain motor patterns which are rewarded, which are preferred behaviorally. So it causes habit learning, causes procedural memory, and then it enhances motivation in that way. Mostly motor related motivation and not just pure psychological motivation. Who does this? Who is basal ganglia? So basal ganglia, the structures that we talk about are the striatum, the pallidum, the subthalamic area in substantia nigra. But this is not that simple. You know, each of these area is further subdivided into further areas. But just this is a quick overcap. So good. So the striatum is the caudate nucleus, which is the green C-shaped, and the putamen. The putamen and caudate has striations that connect them at the anterior end, and that's why it's called striate nucleus. Then you have, in addition to striate, you have the pallidum, which mainly is the globus pallidus internal and external, right behind it. So this structure buried through that you can see is the pallidum. And then you have the subthalamic areas, which is right down here. And then you have the substantia nigra, which is right in the midbrain. So the striatum is further divided into the caudate nucleus, which is a C shape, which has the head, the body, the tail, and then connects into the nucleus accumbens. Then you have the putamen. And then you have the nucleus accumbens, which is connected to the tail of the caudate. Putamen is further subdivided into dorsal and ventral putamen, and we'll talk about it. Pallidum has globus pallidus interna and externa, and then there is a ventral pallidum. The subthalamic area is divided into a subthalamic journal area and a nucleus of Lewis. Nucleus of Lewis is the really subthalamic nucleus that we talk about when we do deep brain stimulation surgeries. And then substantia nigra is further has the pars compacta and reticulata, but there is an area right next to substantia nigra which is called the ventral tegmental area, which functionally and histologically is similar to substantia nigra and participates with it. So these are the basal ganglia that we talked about, and here is an actual gross anatomy pictures. And again, you're seeing the portion of chordate right there forming the lateral wall of the anterior horn of ventricle, fourth ventricle. Then you have thalamus medially, and then internal capsule separates thalamus from the globus pallidus. Medially and laterally is the putamen, and anteriorly putamen will form striations with the chordate to form the striate nucleus. Down here you can see the substantia nigra, the red area, and just above the substantia nigra is the red nucleus, and just above it is the subthalamic area of subthalamic nuclei. And here is the same things in more of a cartoon picture, so it's easier to view. You see the subthalamic nucleus, the substantia nigra, the chordate, putamen, and globus pallidus interna externa. But here is a real good 3D rendition of what we are talking about, and you can see how they're arranged right next to each other. They're very compact and tightly packed structures. You have internal capsule running through it, you have the optic tract running through it, and right outside the putamen, you get the external capsule, and then you get the extreme capsule and the claustrum, and now it's covered by the chordate nucleus. So the chordate is going up around the putamen and anteriorly is connected to it, and this is the body of the chordate nucleus. So how does it work? This is a very complicated picture which summarizes how it works, and my hope is that within next 10-15 minutes I will be able to dissect it in a way that you can follow along, you can understand how does it really work. So let me start with something basic and simple and easy. This is the easiest and simplest thing to understand, that an information is given into basal ganglia, and the area of input is striatum mainly. Most of the input is in striatum, and subthalamic nucleus a little bit. Then the input is given out to output, which is the GPI and substantia nigra pars reticulata, which is functionally similar to GPI and histologically similar to GPI, although anatomically located in a very far distance. So even to simplify it further, you can think of it, input is striatum, NSTN coming into striatum, and output is GPI. And then there is this internal nuclei of basal ganglia, which are basically modulators. They don't receive direct input, they don't give direct output, but they receive input from input and input from output, and then they feed back. So they provide a feedback and feed forward modulation, and they are mainly the globus pallidus externa and substantia nigra pars compacta. So this is basically how a basal ganglia works. Let's dissect it a little bit more. So striatum, let's talk about the input first. So the striatum, which is the chordate and putamen, receives the input from mainly the cerebral cortex. Now, the striatum itself receives input from all of the cerebral cortex. Remember, its job is motor function, but it does not receive just a motor input. It receives input from all the cerebral cortex. So a lot of things are affecting how the motor plan is going to be executed. The mood and other things, other phenomena. And then there is a portion of chordate which receives a very specific input from the motor area. So there is a primary motor area which generates, which starts the execution of motor plan. There is associated motor area or secondary motor area which makes the plan. And then there are other associated specific areas which work with the motor cortex to generate the plan and start the execution. So as soon as the execution is started, the information is sent to striatum to facilitate that internally generated movement. The information is received mainly by striatum, also by STN, but we'll talk about it later. So striatum receives the input. So once the striatum gets the input, how is it going to process it? What is the internal CPU architecture of striatum? There is a gross level processing, and there is a microscopic level processing. So let's talk about the gross level first. So there is a new finding that we understand now as an areas that we call striosomes. Striosomes are these areas which don't stain very well. And what is the stain? The stain is acetylcholine. So the main internal mechanism of integration of striatum is acetylcholine. We don't think about it, but we use it all the time, even in Parkinson patient. So the areas that are acetylcholine poor, don't have acetylcholine, are called the striosomes. And the areas around the striosome, which is most of the striatum, is called the striatal matrix. The matrix further has areas or micronuclei which are called metrisomes, or nuclei of the matrix. And metrisomes are interesting because they receive input from closed areas of cerebral cortex. So you can think of them as like motor units, that a small area of motor cortex is sending information to a specific area in the striatum, which is called metrisome. What is the difference between striosome and metrisome? Striosomes receive input from a different part of the cerebral cortex, mostly motor, while the rest of the striatum receives input from all over the cerebral cortex. So some separation is happening already, and you can see it here better in these color-coded pictures. The blue are the striosomes, and then dark color orange is the matrix with metrisomes in there, not shown. So striosomes are acetylcholine poor areas. The strain is actually for acetylcholine esterase and not acetylcholine, so ACHE. And then it receives input from the frontal cortex and projects to substantia nigra pars compacta. Now pars compacta is not the output, it's the modulator. So now you can see there is an input coming into striosomes which is already being sent to the modulators. So it's kind of an internal processing unit and not a direct link to the output. While metrisomes is the one which is gonna give the direct link to the output of GPI. So, okay, all this input is coming in and it's from so many areas all over the cerebral cortex, and then there are internal connections and there is an internal processing within the striatum. How is that happening on a microscopic level? How is all this information being integrated? So the main integrating unit of striatum is the medium spiny neurons. Medium spiny neurons receive input from all of these connections coming into them. They have large dendrites, very widespread, and that's why they can receive a lot of input. They're getting input from the cerebral cortex and amygdala. They're getting input from the substantia nigra, ventral tegmental area for modulators. They're getting input from other medium spiny neurons. So they are also, so if you stimulate one medium spiny neuron, it may end up inhibiting the medium spiny neurons around it. It is getting input from interneurons, and there are two kinds of interneurons: the cholinergic interneurons, which are the choline-rich interneurons, which is the main, which are far spread in the whole matrix, and then there are the parvalbumin or without choline interneurons, which are present in the striosome. So all this information is gathered by the medium spiny neuron and integrated in many ways. For example, the location of the input on the dendrite can end up having different meaning. So if the location is at the stem of the medium spiny neuron or on the body itself, then it can modulate the whole summated input. These inputs will cause a minor changes to each other, causing an end summated result. But then this whole summated result in the dendrite can be modulated by something which is at the stem, which are mostly interneurons, or on the body, which is mostly the medium spiny neurons around it. So it's a very finely developed mechanism of integrating all this information coming in, and activating one area can end up causing a completely different output from the medium spiny neuron. So a very quick overview. The connections of the medium spiny neurons are from thalamus, which are glutamatergic and are excitatory. Dorsal and median raphe nuclei from the brainstem, they are serotonergic and excitatory. Substantia nigra pars compacta, the internal nucleus modulator, which is dopamine. It's complicated, I'll show it to you. Other MSNs, with again very complicated. GABA is inhibitory, substance P and enkephalin are more modulatory. There are primary striatal interneurons, which are acetylcholine and excitatory, and then there are parvalbumin, fast spiking interneurons, which are GABAergic and inhibitory. Dopaminergic input is complicated. So dopamine has really the complex structure of dopamine integration into medium spiny neuron is the basis of motivation, reward, habit learning, and maybe that is underlying problem with the Parkinson's. It's the poor effort in movement which causes the bradykinesia, akinesia, stiffness, and rigidity. That's one of the hypotheses I've heard from my mentor. So dopaminergic input can do many things. They terminate largely on the shaft of dendritic spines, so they can modulate the whole input coming into MSN. The D1 receptors can potentiate MSN in some situations or scenarios based on what other input is coming in, while they can also inhibit. So they can be either activator or inhibitor, depending on what other environment is like. While D2 is more consistently an inhibitor of medium spiny neurons. Dopamine contributes to focusing the pattern of striatal activity spatially and temporally. And what that means, we'll see in a minute. What is a focus in a spatial and temporal pattern? And then dopamine also has these unusual phenomena that is not seen with any other input, which is the long-term depression and long-term potentiation, which is we know is the basics of memory formation, and maybe that's the underlying mechanism of habit forming and procedural memory and rewards and motivation. Subthalamic nucleus, that is the other input. The subthalamic nucleus input is more pure, coming just from the motor area, does not come from other cerebral cortex. It has no other significant input. It does not get input from thalamus or other medium spiny neurons or interneurons. Its output is more direct towards the output areas of the basal ganglia, which is the GPI mainly in substantia nigra pars reticulata. And then it has the connection with the modulator, which is the GPE, globus pallidus externa, which modulates the current coming in. So it has more straightforward path towards the output. So it's a shorter path. This is the one which used to be called the direct path, and has a more simple structure. And we'll see how that integrates together. Quickly talking about output, the main output from basal ganglia back is from GPI and substantia nigra pars reticulata. GPI mainly projects to thalamus. Now, the way the basal ganglia is working is that thalamus it's an opposite of how a car runs. So thalamus is an engine which is always running at a full speed and has brakes applied on it by the basal ganglia. And the way basal ganglia works is that when cerebral cortex says that I need to do this movement, it lifts up those brakes slowly off of thalamus, and then thalamus is the one that is facilitating the cerebral cortex. So thalamus is always trying to facilitate cerebral cortex, is being inhibited by GPI or has a brake on it, and all this input into GPI is causing in lifting off of that brake in a very focused way, focused spatially, focused temporally. So only the right muscles at the right time get activated and there is no unwanted movement. That is the whole mechanism and function of basal ganglia. So, and then I talked about the intrinsic nuclei. There is globus pallidus externa. There is the substantia nigra pars compacta, which has very complex interactions with striatum, with subthalamic nucleus, with GPI. It gets input from the input and from the output, and it gives output to the input and to the output. So it provides a feed forward, feedback inhibition, and the job of this internal modulator is to make sure that the output going out is very precise spatially, to the right nuclei in the cerebral cortex are being activated, and focused and is right temporally, that they is being activated in the right sequence. One more complexity to the layer is that the whole system is somatotopically organized. So the head areas are different, the neck areas are different, the body areas are different, and the connection is the same way. I alluded to it when I talked about metrisomes. The metrisomes can be thought of as a motor unit. A very small area of cerebral cortex projects to a very precise location or metrisome in the basal ganglia. This is also true for the subthalamic nucleus, by the way. Actually, subthalamic nucleus is the only place which has a double somatotopic representation. So everything is represented twice. So it becomes very complicated when you're doing DBS surgery and finding the right area. The old mapping techniques used to have exact detailed analysis of which part of STN we are in at. Are we in the head area of STN or in the body area or arm or leg area? So this is from a very recent paper that came out, just to show you the complexity of the whole situation. It's not direct and indirect pathways anymore. Basal ganglia is very complex, but we know the function is very simple. The function is to precisely activate the right muscles at the right time and not let other muscles get activated. How does it do it? And this is the new concept. It is being pushed forward by Jonathan Mink, who has done most of the work on it. And it again borrows from the classic pathway but builds on it. So the classic pathway says that there are two disynaptic pathways, straight connection. You have a cerebral cortex projecting onto striatum projecting onto GPI, and then the thalamus is controlled. And you have this cortex projecting onto STN projects to GPI, and thalamus controlled. So you have two disynaptic pathway, and then you have a multi-polysynaptic pathway right in the middle, which is modulating. Why two pathways? What does these two pathways do? Well, the input to STN is mainly from just the frontal cortex, while striatum is all the cortex. The STN is excitatory to the GPI, while striatum is inhibitory to GPI. So excitation through STN is faster, while striatum inhibition route is slightly slower. You get faster activation through STN, and GPI is excited. When GPI is excited, brakes are pushed even further down, hard. And then a slow inhibition comes through striatum just after that, and the brakes are slowly lifted. Why these two pathways? Why we need a first fast brake and then a slow lifting? And the explanation is center surround model. The center surround model says that this is a resting state of the motor parts of the brain, basal ganglia and then brain. So there is a motor cortex area, a circular area of motor cortex which wants to do something, but it's at a resting state. Only very precise center of this needs to be activated. But how do we activate just the center and not the surrounding area, which is going to produce the noise and extra movement? The way we do it is that an STN send a strong inhibition to the whole area. So the whole area gets depressed. And then striatum sends in a weaker stimulation, but is more focused just to the center. So when striatum super adds to the STN signal coming in, only the center is activated. Only that precise part is activated, and you get an activation which is just after it, but there is leftover inhibition that was coming in from STN on the surrounding area. So you get a very precise stimulation with an actual inhibition of the surrounding area. Surrounding area do not even remain at the resting state, they get further inhibited so that you don't get an abnormal motor movement, you don't get a tremor or a jerk or anything like that. So that is how the basal ganglia works. Let me show you the center surround inhibition a little more in a simplified form. Cerebral cortex sending in information to the whole area. It actually wants to stimulate just the center, but there is a surrounding area which is connected and can be stimulated because of the overlaps. The STN has a quick inhibition, so even before the striatum has a chance to work, the STN has inhibited the whole area, but striatum then can stimulate weakly just the center, and then the outer area remains inhibited and center area becomes stimulated. And that's how this works. The role of GPE is to focus this center part to as precise spatially as it can and as precise temporally as it can. And this model can actually explain all these different diseases that we see in movement disorders. So this is a normal function. The color coding basically telling you center surround, inhibition and activation. This is GPI, first line, so it will be opposite of cerebral cortex. Remember, it is opposite functioning. It has to lift the brake, not push the brake. So the central area is inhibited and outer area is activated in GPI, which ends up being outer area being inhibited and central area being activated. This is a normal movement. What's happening in dystonia? In dystonia, the central focus is being lost. There is a bigger center area and then there is a trailing off effect. So you're losing this center surround inhibition, so you're activating more muscles or adjacent muscles than you wanted to. And that's why you get this excessive muscle activation of dystonia that you see. What's happening in the chorea? In the chorea, there are breakthrough popping up of areas in the surrounding areas of activity, which should not be there. And the borders are very vague, so that's why the movements are not exactly the same every time. They come and go, and you get all these extra movement. What's happening in tic disorder? There is very specific area that is being leaking through repeatedly, which is ending up in a precise tic that you see in that person, which is the same every time. So we think it's the leakiness of the surrounding inhibition or damage to surrounding inhibition, which is the reasons for abnormal movement as we see in the movement disorders. So that's now coming back to the idea that I initially said. Okay, well, that's the mathematical model of how basal ganglia works, but how is it really working? As I said, we can put these leads down right into STN or GPI or GPE, it goes down through. We can not only stimulate, we can actually record from these leads going down. What do we see when we record? When we record, we get these discharges, repeated random firing, almost like an EEG or EMG. They are very fast discharges, but then we start to see a pattern on these discharges. We can actually hear a tremor when we put up a wire in our patients during the DBS. You can hear a tremor from the firing coming from the basal ganglia, and even when there is not a tremor, you hear these repeated patterns of firing. And a lot of scientists have sat down and see, okay, what is different about these patterns of firing in the basal ganglia? And this new concepts have evolved, which is the synchronization or lack of desynchronization as a cause of Parkinson's disease, or you will hear the word called beta oscillation. What is beta oscillation? What we have found is that these discharges are desynchronized or very random at a basic level in a normal person. But when we have somebody with Parkinson's disease, there is a loss of desynchronization, there is a loss of randomness, and a more organized or synchronized firing pattern evolves. The rate of that firing is 15 to 30 hertz, so that's the beta range as we talk about in EEGs. So that's why we see these oscillation of firings called beta oscillations that are present in a Parkinson patient. And when they are treated with medication or DBS and the symptoms improve, the beta oscillations go down. So we know that they are linked with the pathology, that beta oscillation at least act as a marker of the disease symptoms or severity. And when you improve the symptoms or severity, the beta oscillations get better or go away. You can see this is the plot of the frequency plot of this, and you see the blue one has no jump in the beta range, and the red one has a jump in the beta range. And now this oscillation concept is emerging even further. There is a new paper that proposed that beta oscillation tendency is always there. The basal ganglia is always trying to get into beta oscillation, but is being broken up again and again, and it's loss of that breaking up that beta oscillation that ends up causing the Parkinson's disease symptoms. Now there are new oscillations have been proposed. There was a recent paper came out with theta oscillation, which are even faster oscillation. There's even more data. People have tried to adjust the programming frequencies to especially break the beta oscillation. It hasn't worked. So there is more to beta oscillation that we don't know for sure yet. That this is not the final answer, but at least it is a marker of what we're seeing. So it is kind of very different than what we're thinking about pathways in basal ganglia, but this is going to be the new science of basal ganglia and how these activity combines and forms, what waveforms are formed. So in summary, a tonically active basal ganglia provides a brake on the motor function by breaking the thalamus. Activation of motor plan generators in cerebral cortex results in a focused facilitation of required neurons while inhibiting surrounding neurons. Various structural nuclei and histochemistry of the basal ganglia provides the physiological basis of this mechanism. Activation through STN by direct motor cortex provides a quick increase inhibition of the neuronal area, the hyperdirect pathway, and a slower activation through striatum provides a focused facilitation of the precise motor plan generator neurons. And internal nuclei provides further focusing and error correction, and substantial angular pars compacta and VTA through dopaminergic input provides long-term modulation of this pattern of activation and integration of reward and motivation resulting in habit learning. Thank you so much.
Bismillahirrahmanirrahim. I congratulate Professor Aslan and his team for organizing first conference on Parkinson disease and movement disorder. So I just have my own slide just to give a touch, national touch, and most of the videos, they will cover all the aspect of phenomenology, and they are what we have seen during the last 20 years in Pakistan. So what are movement disorders? Basically, they are characterized by either excess of the movement or lack or paucity of the movement, and they are unrelated to weakness or spasticity, because you can get clonus when there is spasticity, and similarly there may be weakness associated with some abnormal movements. So basically two types. But before we go into detail, just a few terms which we are going to use frequently. Hyperkinesia means excessive movement. Dyskinesia, unnatural movements. Kinesis, any movement is called. Hypokinesia, decreased amplitude of movements. Bradykinesia, slowness of movement. Akinesia, loss of movement. What are voluntary movements? Because yes, this is the terminology we are going to use. They are intentional, planned, or self-initiated, are externally triggered in response to some external stimuli, just turning your head to a loud noise. And what are automatic movements? They are the learned motor behavior. Just we are speaking, we are walking, they are all automatic movements. Involuntary, they are not under conscious control, and they are often not suppressible, such as most tremors and myoclonus. So broadly speaking, after going through this phenomenology, we have a very fast going movements called hyperkinetic, and the slow or decreased movement which are hypokinetic disorders. And hypokinetic traditionally are called akinetic rigid syndromes, and the best example of this which we use and which we are going to discuss today is the Parkinson disease and various Parkinsonian syndromes. But there are a number of conditions where you can get hypokinesia, which are listed here, but I will not go into those details. And what about hyperkinetic movement disorders? 5 movement disorders are very common, and most frequent is tremor, followed by chorea and dystonias, myoclonus, and tics. But there are a long list of abnormal hyperkinetic movement disorders. You go on naming them, and the list is increasing. So, just few words about Parkinson disease. I know there will be a detailed discussion on Parkinson disease. We have classical features. ये वीडियो नहीं आती इस पे, अच्छा ठीक है. So this is the very classical example of Parkinson disease, and if you see this patient, I think it explains all the features. Patient has masked face, patient has bradykinesia, patient has resting tremor, patient has cogwheel rigidity, patient is walking with slow, short step, flex posture, and you can see this is, and when you talk to him, his speech is very typical monotonous speech. इसमें वो साउंड के लिए लग जाएगा. This writing is very micrographic type. जी लगा. And you are going to have these features in the detail when we have the discussion on Parkinson disease, and a number of syndromes other than idiopathic Parkinson disease which are related with those Parkinsonian features. Now, problem when you have hyperkinetic syndrome, we should have an approach, and 3 or 4 things we should note for each patient, and one should answer them. Step 1, is it rhythmic movement or not? So if it is rhythmic, what is that movement disorder? So rhythm you see with tremor. So it's a rhythmic oscillation of a body part. If it is not rhythmic, then you go to the second step and you note, okay, is it sustained or not? Now sustained element comes in dystonia. Although dystonia is stereotype as well, but sustained component is specific to dystonia. Stereotyping may occur with some type of tics and some other movement disorder. So you have dystonia. And if this is not, you go to third step, when either it is not rhythmic and it is not sustained, then you have all the other movements. You name all the other movements in that category, namely chorea, tics, and myoclonus. So with this approach, we discuss only briefly about these things. Tremor is by definition is the rhythmical oscillation of a body part. It may be resting, it may be postural. There are a lot of classification of system about the tremor, but traditionally these are intentional, physiological, mixed type, and task specific. So this is resting tremor, which you have seen videos here, and you can see this is the resting pin rolling type of tremor. It disappears when the patient start moving hands or outstretched hands, and it is increased by excitement and when you are talking to the patient. This is postural tremor. It is absent at rest, but it appears when the patient is holding the hand against gravity. Usually it involves upper limb, but may involve head and wall. It causes lot of difficulty. Young people come with postural tremor, they have difficulty in taking tea, coffee, but when it is resting, it disappears. But patient can continue all the other things. He can walk normally, but he has difficulty in writing. But he can walk normally. No tremor while he is walking. This is the intention tremor. When you ask the patient to touch a target, then two types of phenomena you see. One, the patient try to reach the target and patient then pass point that. So you can, this is a feature of cerebellar tremor. So he has difficulty reaching that target. Now what is dystonia? So dystonia basically, as I already said, is a sustained muscle contraction causing stereotypes, twisting movement or turning movement or abnormal posturing. So that these are the few important words about dystonia, and other things are that this may be partially relieved by sensory tricks. Yes, oral mandible dystonia may be relieved by putting fingers or chewing the gums, or cervical dystonia may be relieved by touching the hand and back of the neck, and that may give some relief. So we have a classification according to the etiology, whether they are primary, whether they are dystonia plus, where there are additional features, according to the age of onset and according to the distribution. I think that is more important when we are clinically managing those patients, that whether this is focal, segmental or generalized. So focal when single body part is involved, segmental when continuous two components are involved, multifocal involved two non-contiguous part, generalized trunk plus two other side, and hemidystonia confined to one side of the body. And focal dystonia examples are blepharospasm, oromandibular, cervical, laryngeal, limbs. This is the patient. This is a child. We used to admit all the pediatric and neurology cases in 1994. So we have lot of pediatric group for the movement disorder. So he came with progressive generalized dystonia at the age of 4. So this is basically primary dystonia, and which is childhood onset. This is adolescent onset. He is married now, but the problem started around 13, 14, and then it involved the whole body, and this has generalized dystonia. By the way, he is married and has 6 children. Twenty years. So this is secondary dystonia. I did not show video just to waste time. Not to waste time. This is due to Parkinson disease. So very frequently, young patient we have number one cause of Wilson disease, and this is focal dystonia involving the eyelids, orbicularis. And this is blepharospasm. These are the two examples of hemifacial spasm involving the right side. So you can see the involving of the eyes and the face. One half of the face is involved. This is hemifacial spasm. This is a patient with oromandibular. This is two type, jaw closing and jaw opening. And here she has opening of the jaw. So this is sensory tricks. So now you may have blepharospasm with involvement of oromandibular dystonia. So this combination is called Meek syndrome or Brugel syndrome. And why Brugel syndrome? You can see here, she has involvement of both bilateral blepharospasm, and you can have the oromandibular edema. Now, Meek was a French neurologist, but what about Brugel? He was a painter, and he painted this painting which he called The Gapper. This is just during the yawning, he took the painting of a yawning man. And you should imagine when you yawn, the eyes closes and mouth is open. So on this, that was called, as you can compare the patient and this painting. So this is the gappers. Now this is the female. She came with 2 years history of cervical dystonia, basically spasmodic torticollis with element of laterocollis and retrocollis. And she did not go out of his house for the last 2 years because as she moved spasmodically, the neck will turn to the other side. And you see after the Botox, now she is back to normal. So this was after a long time she was out of home and started enjoying life. This is a patient, he is from Islamabad, he comes to Lahore and he is laterocollis, and see after this is in WhatsApp his picture after 10 days of the Botox treatment. This is laryngeal. This is laryngeal dystonia, adductor type. जैसे आवाज़ घुटी होती है, they have difficulty in producing the sound, not typical hoarseness, but something coming through the, squeezing through the tight vocal cord. So a different diagnosis is telling that he was told that he has right recurrent nerve palsy and other thing, but this was laryngeal dystonia. This is the writer's cramp. As you see here, there is when they start writing, this is task specific. They can do everything. They can drive, they can brush, they can shave. The only problem occurs while writing, and this is very underdiagnosed in our general, under the hand of general physician. People are not aware of this phenomena, and see when they start having dystonic cramps of the hand and starting having. Then we have a group of paroxysmal dystonia. There are 3 types. One is precipitated by after a period of stress when they start moving, and second, they may occur without any movement, not related with any rest or exercise, and then third is exercise induced. And we have 2 families which are hereditary, and we have 1 sporadic case which is related with multiple sclerosis. This may be, what happens is, he was lying, when he started walking, he developed this dystonia on the right side, the hand and the lower limb. His father had this problem, his one brother had this problem, and it responds to very small dose of carbamazepine, Epivol or phenytoin. लेकिन इसके लिए he needs to have a proper rest. If you start after very few short period of rest, this will not appear. So this is paroxysmal kinesogenic dystonia. Now there are dystonia plus syndrome, but one is the DRD, other is myoclonus dystonia, and second rapid onset dystonia Parkinsonism. And this is a patient we have. He came with a long history, inability to walk, not diagnosed, told as a cerebral palsy. Now this is very interesting. We have to apply those 3 rules: rhythmic, sustained, अब देखें इसमें क्या है. एक चीज तो है कि स्टीरियोटाइप है. B, there is sustained element, at least in the neck. Third, there is a fast component, jerking element. So this is myoclonus dystonia. Now we have what are chorea? Chorea are brief movements and which are neither rhythmic nor sustained. They are rapid, jerky, non-stereotype, more affect distally. The slower form is called athetosis and the very violent proximal type. So they are spectrum of the same from slowness to the high amplitude, and this is called bellismus. And these are the few cases which we have. So ये patient है, this is a patient with hemichorea, and if you look at her, she has some lid lag and goiter, and she had hyperthyroidism. I don't know why with hyperthyroidism she had hemichorea. She should have a generalized chorea, but you can see here prominent goiter, and the other lady, this is Sydenham chorea. She came, she had features of rheumatic heart disease. Her age is about 14, and she had evidence of echo evidence of mitral valve disease and high ESR. Sorry. This is what is myoclonus? Myoclonus is recognized with its speed. It's a very lightning-like muscle, fast, rapid, jerky movement of the body. This is asterixis. Asterixis are sudden brief lapses of agonist muscle during maintenance of posture. They are negative myoclonus, classically seen in hepatic failure but may seen as a metabolic encephalopathy. You see when she holds hand, the hand drops. This is negative myoclonus. Now what are tics? Tics are basically abrupt, emerge from quite background. They are stereotype most of the time. May be simple or complex, or इसमें motor भी हो सकते हैं, vocal भी. Motor can take the repeated movement of certain body parts like blinking, like facial movements, and then there may be different sounds. So you can see this is facial tics. And this is to relieve the inside. They have OCD and they relieve the inside tension or stress. ये एक चाइल्ड था जो एक्यूट ऑनसेट ऑफ फेशियल टिक से आया. अगर आप देखें इसके फेस पे, ये फेस पे, आइज पे ये है, एंड ओनली 1 week हिस्ट्री आफ्टर ए फिब्राइल इलनेस विद बिहेवियर डिस्टर्बेंस. और इसके बाद चेंज इन पर्सनैलिटी आई. एक शॉर्ट हिस्ट्री थी. So what is this? He has a history of fever. He is ASO titer for more than 2000. So this is Panda's syndrome, pediatric. ये disorder है after associated neuropsychiatric disorder associated with streptococcal infection. Stereotypy. What are stereotype movements? Although we said that dystonia is stereotypy, but classically stereotype are coordinated movements that repeat themselves constantly and identically and interfere with the normal activity. So we have one slide. अब ये स्लाइड बहुत पुरानी है, 96 में बनाई थी, तो वो पुराने ज़माने की वीडियोज़ हैं, वो थोड़ी सी ख़राब हो गई थी. और ये एक फीमेल है, 8 years. फर्स्ट ईयर was normal development, then she acquired aphasia, stereotype movement, constant movement of the hands into one another. So rubbing movement hai, and constantly whatever she is doing, you lose his hand, she again start doing this thing. She is not able to walk. She has acquired microcephaly, and this she has scoliosis and she has spastic paraplegia. और ये इसलिए से मुझे वीडियो अच्छी लगती है कि एक दफ़ा वन प्रोफेसर emeritus from one of the college from London came and he delivered a talk in KE about 200 people were there. Professor Hassan Aziz invited him from Karachi, and he delivered last 10 minutes of talk on Rett syndrome. And at the end he said, has anybody seen Rett syndrome? When I said yes, so he smiled with a very tone, said, but patient was there, I brought this patient and he saw the patient, and then he said two things. Number one, he said, this is my first case of Rett syndrome, despite I might deliver my talk. And second, he said, after seeing this patient, I now realize I must have missed 100 of Rett syndrome. So मकसद कहने का ये है कि movement disorder and epilepsy, unless you see them, you may see them in your practical life, but you may not be able to pick them. So this is Rett syndrome. So what is the systemic approach? This is my last slide. So if you have a movement disorder, first identify what are the different types of movement disorder. जैसे Parkinson disease में you may have predominantly hypokinetic disorder, but tremor is hyperkinetic. So a disease, Wilson disease, may have marked bradykinesia, but they may have choreoathetosis, another combined movement disorder. So several movement disorders may have a combination of many movement disorders. So, but define what is the dominant movement disorder, identify what are the other neurological features like cognitive decline, like cerebellar sign, like we have intention tremor. This patient was a case of dyssynergia cerebellaris polymyoclonica. He had polymyoclonus and cerebellar sign. So associated non-neurological features, and finally give a clinical diagnosis and then workup. You may have final diagnosis, like I said, Wilson disease, genetic study confirming Rett syndrome or other things. So with this, I thank you all.
Everyone can hear me? Okay, great. Bismillahirrahmanirrahim. First of all, I would like to start with some acknowledgments. I would like to acknowledge two people in particular, Dr. Javed and Dr. Arsalan Ahmed, who are the driving force behind this meeting, and they were kind enough to invite me, and the Movement Disorder Society and the curriculum that was routed to us through Dr. Bhatti. So the topic is diagnosis and differential diagnosis of Parkinson's disease. So what are the cardinal features of Parkinson's disease? The diagnosis of Parkinson's disease is a trap, T-R-A-P. And I'll explain to you why it's a trap. It's a trap, one, because T for tremor, R for rigidity, A for akinesia or bradykinesia, and P for postural instability. And the other reason it's a trap is it's a diagnosis that even experts miss. Now there was a study in the UK in the mid-90s in which they autopsied all these patients with Parkinson's disease followed by movement disorder specialists. Treated for many years, died, diagnosis, Parkinson's disease. On autopsy, they were wrong 20% or more of the time. So these experts who were treating all these patients were wrong in 1 out of 5 patients. So diagnosis is a trap. It's tricky. It's also possible to miss Parkinson's disease. In Urdu, we call it Rashe ki bemari. But you know what? It's absent in 1/5 of the patients at any point of the disease. So tremor is a classic symptom of Parkinson's disease, a resting tremor. That's how we diagnose Parkinson's disease. But it will be absent in 20% of the patients. You know, then rigidity, so T-R-A-P. Rigidity is another feature of Parkinson's. What is rigidity? When we test resistance to passive movement, that is rigidity. And there's a special pattern of rigidity which I'll demonstrate in a little bit. But you know what is the key feature of Parkinson's? It is slowing of movement, bradykinesia or akinesia, which are used interchangeably. Slowing of movement is you cannot diagnose Parkinson's without slowing of movement. That's the primary cardinal feature. So you need, as I'll explain later, you need slowing of movement, bradykinesia, and one other feature. Postural instability is the late feature. Now you can see this classic resting tremor. He's demonstrating rigidity. This patient is slower than the normal control. So remember TRAP. It's an easy acronym to remember. So other than trap, what else is there? Well, you recognize patients with Parkinson's, you go to a shadi and you see some of them. So they have a slight stoop, they have reduced associated movements. Arm swing is reduced, so they don't swing their arms as you see over here. And as we see in this gentleman we saw earlier, they have a mask-like face. They don't even blink. All movements are decreased. They don't swallow so often. So we all produce 1.5 liters of saliva a day, so some of that saliva might drool. Drooling may be a feature of motor impairment. Reduced blink, the handwriting becomes small, micrographia, so all the movements are reduced. So we talked about motor movements, and dopamine is central to motor movements, but it's also involved in mood and a lot of psychiatric problems. And dopamine is not the only problem in Parkinson's disease. They have norepinephrine deficiency, serotonin deficiency, acetylcholine. So all kinds of brain functions will be affected. And it's not just the brain. We have almost as many neurons in our gut as we do in our brain. So Parkinson's affects the heart, the nerves of the intestines, the gastrointestinal tract. So we have many non-motor features of Parkinson's. And now it's interesting that I've come across studies in which quality of life in some patients may be affected more by the non-motor symptoms. And this often we neglect. Anyway, the non-motor, there's a lot of autonomic non-motor symptoms like orthostatic hypotension, urinary symptoms, even incontinence, constipation, sweating, dysphagia, erectile dysfunction, and some autonomic symptoms like constipation can start 10 years before the beginning of motor symptoms. Just like in sensory symptoms, anosmia, loss of smell, can happen 1, 2, 3 years before the onset of motor symptoms. Other sensory symptoms other than anosmia include pain, restlessness, a desire to move, and internal tremor. So they have this tremor inside which you can't see. And the poor people always get dismissed. If we doctor can't see them, it's not real. But they actually have this internal perception of a tremor. Fatigue. Sleep problems are very common. Other than the insomnia and the daytime somnolence, RLS, restless leg syndrome, just RLS can devastate a person's quality of life. REM, sleep behavior disorders, in which these patients, when we go to sleep during dreams, our body becomes atonic. Only our eyes are moving and the diaphragm is moving. But in these patients, the body doesn't become atonic. So they're acting out their dreams. If they're dreaming of a boxing match, they'll be lying in bed and boxing. And this can be disturbing for the partner. Then a lot of neuropsychiatric problems like depression, anxiety, panic, apathy, hallucinations, and dementia. A couple of points. In Parkinson's, incontinence and dementia are late features. So although they happen in Parkinson's, they tend to be late, and we'll talk more about that. So a little bit about the differential of Parkinson's. Toxins. All kinds of poisons can poison the basal ganglia and cause symptoms of Parkinson's. And you can, sometimes we do MRIs and we see abnormal basal ganglia signals, and then we go back and ask, and then we realize that they had methanol or something like that. But actually we should ask about exposure, welders, chemical exposures, methanol, kachi sharab peete, I see a lot of young men in Karachi, especially in the month of Ramzan when the wine shops are closed, they have homemade alcohol and they come blind. There are epidemics, 50, 60 people in one night go blind, and some of them develop symptoms of Parkinson's as well. Infections, not common, but we should know about it. Encephalitis lethargica was, I think 100 years ago, it was a big problem. HIV encephalopathy, syphilis, fungus, Whipple's disease, Creutzfeldt-Jakob. I've seen patients with Creutzfeldt-Jakob, prion disease, present like Parkinson's. Now, another very common problem is drug-induced Parkinson's disease. I think there's a talk on that, so I will not talk much about it except to say that it can look very much like Parkinson's, and even if you stop the medicines a month ago, it can take 6 months or sometimes even a year to go away. So even if they've stopped the medicine 3 months ago, they could still have the symptoms, and antipsychotics, Stemetil, Maxilon, those are the common ones. I've seen patients with valproate, as anti-epileptics with EPS, extrapyramidal. With lithium, it's quite common. Then these are some which I think are frequently missed or misdiagnosed, and so there are a lot of degenerative problems. Wilson's disease we should never miss. Young person, just make sure somebody takes a good look at their eyes, and if you want to send a ceruloplasmin level. PSP somehow is often mistaken for Parkinson's disease in my experience. Multiple system atrophy. Less commonly Alzheimer's, corticobasal syndromes, other dementias, Huntington's disease in the young, and less common degenerative problems. Quite frequently vascular Parkinsonism, you have basal ganglia, you get strokes, you get dysfunction, you get symptoms of Parkinson's disease. Hydrocephalus we should not miss, because NPH, normal pressure hydrocephalus, can be reversed with surgical treatment, and so we must remember the 3 W's of normal pressure hydrocephalus, which is wet, which means incontinence, wobbly because they have a Parkinsonian